Good morning. Hi. Oh, great. Okay. You are awake. My name is Lisa Gallagher. I'm Senior Director of Privacy and Security for HIMSS, and I'm going to be serving as your moderator today. So a couple of logistical items. We have a 75-minute panel. We have 4 speakers. Each of them is going to give you a few minutes of their time to talk about their work and experience in the area of BYOD. And then we'll have quite a bit of time for questions, comments, and discussion. We'd like this to be very interactive. We know that you all are likely dealing with this in your organizations, and we're here to talk through the issue and have a dialogue. So we'll make sure we have plenty of time for that. So I want to start out by asking if everyone in this room knows what BYOD means. Who doesn't know what that means? I actually had a couple of people ask me today, and I said, well, it used to mean bring your own drinks, but now it doesn't mean that anymore. So we know, just from observation and experience, that BYOD is making significant inroads in the business world, in our own environments. And the technology is already in use. People are connected to networks, and what I hear from CIOs, CSOs, et cetera, is they can't stop it. It's like a freight train running them over. We know that employees feel that it's going to help their workflow, make their job easier to use their own device. Organizations believe that it increases morale and convenience, makes them look like they're a very flexible employer who likes to work with their employees on making their life easier. But we also know there are lots of challenges. So what are the challenges for healthcare? Well, if we do this in a way that's not managed, we're already seeing data breaches. HHS actually came to HIMSS and had a conversation with us and said, listen, fully 40% of the breaches that are being reported to us are coming from lost or stolen mobile or portable devices. We need to get a handle on this, et cetera, et cetera. So there's a lot of concern. There are policy and management challenges, there's legal and liability challenges, and technical challenges as well. And that's where our wonderful panel comes in. So we have 4 speakers today. I'm going to give you a short background on each of them, but I would refer you to their website for more detailed bio information and contact information. So Brian Balow is our first speaker today. He's a member of the law firm Dickinson Wright, PLLC, where he focuses on information technology, intellectual property, and healthcare law. Next, we have David Holding. Did I say that right? Healthcare Privacy and Security Lead Architect at Intel. He's responsible for tracking healthcare trends, related privacy and security issues, and best practices for managing risk. We have Jay Saviano. He's Director of Healthcare Business Development at Commvault, which is a data storage software company. And Eleanor Chai, Executive Director for Health at AT&T, leading on product and offer development. So at the end of the 4 speakers, we will have a Q&A session, which I will moderate. And with that, I will introduce Brian.
Thank you. Morning. Thanks for coming. I get to play Darth Vader, which is what I always get to play at these conferences, because I get to come up first, talk about all the bad stuff that's going on out there with BYOD or social media or both. But how many of you, she touched on BYOD, how many of you allow BYOD in your organizations currently? Okay. And how many have a policy that addresses that? And how many of you have read the policy that addresses that and know what it says? And that's sort of the rub on some of this. It's one thing to have a policy, it's another thing to implement and train on it and enforce it. And you're not doing yourself a lot of good by having it and then not implementing it. So I'm going to touch on that a little bit later in here. But many of you know HIPAA was pretty sleepy for a long time after they introduced it, and there was not a lot of enforcement activity. But the confluence of the technology and the press for electronic health records has changed that landscape drastically. And OCR is out doing enforcement activity now. They're doing audit activity. Many of you may know about that, security audits. They selected 115 lucky covered entities to audit, and they have been doing that. I think they expect to wrap up by the end of this year. I haven't checked recently where they are in that process, but it is real. As far as the other enforcement activity where they get tipped off, I'm just going to run through a few recent examples so that you know, again, this is a real issue. Massachusetts Eye and Ear Associates in September, that was a $1.5 million fine. That was a laptop that was stolen or lost with 3,500 patients' information on it. So that was $1.5 million, along with the 3-year program that they have to follow to make sure that they then do have the correct policies in place to ensure there aren't any further breaches. August 30th, Signet Health. They were fined, and it was upheld by a federal district court, $4.3 million. And $3 million of that was because they would not cooperate with OCR in the investigation. So they got an additional $3 million for not cooperating. Alaska Department of Health and Social Services, $1.7 million, and that was the theft of a USB device, an employee's USB device. And then $100,000 Phoenix cardiac surgery was fined, and that had to do with putting patient appointment information on publicly available internet websites. So they're out there, and these are all very recent. There are other investigations ongoing right now. They are fining, and if you think about it, for Alaska, $1.7 million for one USB device. So this is an issue, and it is real, and it's live, and it's not going to go away. So with that, because we have limited time, I'm going to skip through a lot of these slides, even though we have this nice animation on this one. But I want to go really to, we know what the concerns are, but you know, it's not just the PHI. That, for this group, that's the keen focus. But you have state breach notification laws. You have data destruction laws that relate to litigation. Litigation holds, wage and hour laws, and malpractice issues as well that relate to the use of mobile devices. But what I want to get to is this, really the why have a policy. Lisa talked at the beginning about, you know, the cows sort of left the barn on this. And when I spoke on this a couple of years ago, you know, the lead into this would be, well, you really have to assess, do you even want to allow BYOD? And at that point, there was an opportunity for some organizations to say no. Law firms are a lot like health care organizations, even though lawyers and doctors are like oil and water. Our organizations have some similarities because we handle very sensitive client information. And we've been through this at our law firm. I saw the beginnings of a full-blown fist fight between one of our attorneys who liked his Apple laptop and our CIO, who was saying, no, we're not allowing any other devices than the Windows platform that we're on. And since that time, you know, we had a very strict policy. We are now, you know, I have an Android device where I can access client information. Now, it's all encrypted and everything's, you know, we have a policy in place. But today, the question of whether you want to allow BYOD, I think, again, the cows sort of left the barn on that, and we're out there and the mobile technology's out there, and it's maybe too late to unring that bell. So assuming that you're going to allow BYOD, questions are, if I'm going to management at a company and I'm a CIO or a CTO, CSO, and I want to go to my management and get the resources that I need to get a policy in place, the first question I'm going to be asked is why? And, you know, here are four, I think, very good reasons, and the first one is the most important reason. You want to protect your patient's rights. At the end of the day, if you want to look at a mission-driven reason to have the policy, what better reason than to protect your patient's rights? And I don't mean that necessarily from a liability standpoint. If you're a health care organization, your number one priority ought to be your patients. So the second is to instill professionalism throughout your enterprise. You can use policies and procedures to kind of drive behavior if they're done the right way. Protect your organization from liability, obviously, and your employees from liability. because they, in some circumstances, can be named as well individually in a lawsuit if they have an unfortunate circumstance like losing a laptop or a USB drive. We touched on this. So considerations when you're putting your policy together. You have to understand your IT enterprise. You know, what is the framework, what are the platforms, those kinds of things. You have to understand the economic pros and cons of BYOD to your enterprise. So how does it actually fit in? You know, there's not one size that fits all. I think you all know that. It's just the reality of it. And I don't mean that from organization. I do mean it partially from organization to organization, but I also mean it within an organization. Understand the risks to your enterprise related to BYOD. I think a formal risk assessment is a really good idea. And then determine, based on these considerations, I said whether to adopt, but really we know that you're going to. The stakeholders in that process, you need your senior management involved for resources and institutional support, chief medical information officer, privacy officer, IT officer, staff, because they're going to be involved in the actual implementation. I think it's a good idea to have them involved earlier rather than later. There's nothing I like less than having a client call me and saying, hey, we got this contract and we're ready to get it signed, but would you take a quick look at it? You know, we want you to sign, we want to sign it tomorrow. Same idea here. I think the people who are actually going to be involved in the nuts and bolts ought to be involved relatively early. Legal and regulatory and human resources really as much on the enforcement end as anything else. There are many policies, other policies, that affect a BYOD policy. I consider a BYOD policy as a discrete policy, but it touches on or may be embedded within or correlated to all of these other policies. Acceptable use, security policies, social media, remote access, remote working policy, incident response, breach notification, privacy policies, and litigation hold. So I see it again as an element that is tied into all of these other policies. Now, if you want to name the overall policy, put all these in one overarching policy, there's nothing wrong with doing that. But what I'm suggesting is the BYOD element is affected by all of these other policies. So they need to tie together, they need to make sense together, and then you make your decisions about who can use their own device, under what circumstances they can use their own device, for what purposes can they use their own device. What kind of issues should a discrete BYOD policy address? These slides on the website, are they accessible, these slides? Okay. Okay. I would suggest going and clicking on this link. This is a good sort of iterative document that can kind of walk through the issues and the considerations when you're determining what issues you should put in your own BYOD policy. And then again, as I mentioned, you should incorporate the other related policies, privacy, acceptable use, by reference in your BYOD. Policy content, why. You need to have the purpose of why you're having it, patients' rights, organizations' assets, rules of access, prevention of privileging, licensing violations. That's another issue with mobile devices you may be aware of, because it allows physicians and other healthcare providers to interact long range. There's some concern about practicing medicine outside of the jurisdiction within your license. And then the delineation of work versus personal use. You should have a scope in the policy content. What are the supported devices? They should not be jailbroken. That means, worked around so that they can avoid certain security elements that might be baked in. Whether you want to reimburse for the cost of the device. What are the approved applications that can be included on that device? Like when I try to upload Angry Birds onto my laptop and it says I don't have administrative privileges. That should be delineated. And then are there other limitations that you want to impose on a BYOD device, like no cameras? Who should be affected by the policy? Employees, obviously, but also if you have interns who are unpaid, ought to be brought within. Students, and a lot of teaching facilities out there, it ought to be made clear that they're involved. And any contractors or consultants, really it's anyone that you can think of that might have access to and use of any kind of PHI or other sensitive information. How? The roles and responsibilities should be described in the policy as well. The senior management's role, we touched on these, and then enforcement. Enforcement is really important because, again, as I said at the beginning of the discussion, it means very little to any kind of regulatory agency if you have a policy and people violate it and there really are no consequences for those violations. So the enforcement element of it should be clear for the employees and any other users of BYOD that if you violate the policy, this is what will happen, and then to follow through and making sure that it in fact happens. And then when, it should be, when you put the policy in place, should be yesterday if you're already allowing BYOD, so I wouldn't wait at all, and today if you've decided that you do want to allow BYOD. Federal government has a Bring Your Own Device toolkit. There's the link to that. HIMSS has Bring Your Own Device and consumerization. There's the link to that as well. This is our disclaimer, so I would ask that you take a minute and read it. But we do have to put that out there. So with that, I'm going to step down, and we'll have the next speaker. Thanks very much.
All right, can you hear me okay in the back there? All right, thank you, Brian. Excellent foundation. Certainly agree with all the best practices around policy. So where I wanted to add to that, is it coming up? So just this one here. Oh, it's going to load it. Yep, thank you. I wanted to start off with a little poll here. How many people in the audience have a smartphone of some kind, a tablet of some kind, and a laptop of some kind? All three. The vast majority of us have all three, right? And it's not like we just use one of them, right? We use them for different things, right? Different devices for different use cases. That's what we're strongly advocating. We really don't see one of these devices replacing all the others. They get used for different things. And the challenge is really securing all of them across the diverse continuum. It's not only the different types of devices, of course, it's the different flavors of devices. You got iOS, you got Android, you got Windows, and so forth. And now we have hybrids coming out, convertibles, and a rapid proliferation at the low end of the spectrum where we have all these purpose-built sort of healthcare devices. So it's a real challenge, and the use cases are not all just using one device, right? Some of the use cases can go across devices. Like we might have a clinician outside of a clinic getting an alert on a smartphone, then going into the clinic, doing rounds with the tablet, finishing off with a video conference call on a laptop or a report or something like that. You really need to secure that whole use case, that whole long-running use case. And there's many others that would touch even more broadly than that. So this is a real challenge. How do you secure this whole diverse continuum of mobile devices? Well, one of the tools we see people using is the compute model. And we see a lot of healthcare organizations considering thin client as a tool to mitigate risk. Of course, it does a great job of moving the PHI off of the mobile device and onto the strongly managed, strongly secured back-end servers. And that's a very effective mitigation of risk of breach through loss or theft of mobile device. However, thin client is appropriate in some use cases, but we caution people applying it to all use cases. Here are some scenarios where it can fall down. And keep in mind that security is not just about confidentiality. Security is about availability. It's about timely and reliable access to information. And if you ask a healthcare worker what's more important, being able to get to information in a timely and reliable way or preventing, breach of confidentiality, they'll almost always say the first one. They've got to be able to get to the information, right? That can directly impact the patient health. Not to downplay the importance of protecting confidentiality and avoiding breach, but availability is really important. And if we put all our eggs in the thin client basket and our network's not 100% or available or performant, that can be a real problem for availability, right? Thin client just doesn't work there. And another challenge we see is with thin client, oftentimes the applications that are being run on these back-end servers were designed for a large screen mouse and keyboard, and they're being used through a small touchscreen device. So we need to be careful about user experience. Are you really giving the healthcare worker the user experience they need with that thin client? Okay. So we need to consider all those things when we choose the compute model. What I hope to leave you with today is impress upon you the diversity of this environment we need to secure across the long-running use cases. Compute models are a very effective way of managing risk because they control where the information is at rest. Is it the client, the server, or both? How does it move over the network? Thin client is one option, but there's many other compute models that you can consider. And one of them is, secure client container model, where you have some kind of a secure container on the client device, the mobile device. It's encrypted, it can be remotely locked and wiped, it can be managed. And what it allows is some limited local storage of protected health information that keeps the healthcare worker productive even if the network is not 100% available or performant. There's some very important use cases, home care, rural care, even in more dense scenarios, dense settings, city settings, where you could have network availability challenges, and that kind of tool to help with availability can really be a godsend. So definitely consider all the different compute models. Some of the ways that secure container is implemented, virtual machines. You could have a virtual machine on the client device, one for personal, one for healthcare. And the healthcare one's strongly protected and managed, and there's sort of that secure partition between them, right? Another one is sandboxing technologies. You see with some MDM solutions coming out, where you have a secure sandbox that can contain the healthcare information, and it can be taken offline. So compute models are definitely an important tool, but just like we have choosing the right device for the right use case, choose the right compute model for the right use case. So one of the side effects I wanted to talk about with BYOD is how it's empowering workers with more tools than they've ever had before, right? And what this does is it really doubles back the pressure on us to provide security that's not only strong, but is usable. Because what happens when healthcare workers encounter a security solution that gets in their way and impedes their ability to deliver healthcare? Well, they've got that personal device in their back pocket. They've got the USB key. They've had personal email forever. They could text. They've got Dropbox. They've got Evernote. They could take pictures, video. And what these can result in, from the healthcare workers' standpoint, security is impeding the quality of care. And in many of their minds, this could be justified seeking a workaround that delivers better quality of care. However, there can be many hidden risks with these kind of workarounds, as we well know, right? So again, we've got to provide security that's not only strong, able to resist increasingly sophisticated malware, but we've got to provide security that's usable. What does that mean? It needs to be performant. So if we put encryption, here's one example, encryption on a mobile device, it cannot slow that device down, or you risk compelling users to use alternatives which bring risk. Security needs to be robust to resist malware, otherwise the device can be infected. The reality with malware is it's getting more sophisticated to the point where it can actually disable or circumvent safeguards or security controls. So future security controls need to be very robust to ensure malware doesn't deactivate the controls and doesn't infect the device. Because again, if the device is not working, if it's infected, those users might seek alternatives. Security needs to be usable in the sense. A great example of this is two-factor authentication. We all, I think, agree that username and password is weak and it's fraught with problems, right? Two-factor authentication is the natural way to strengthen your authentication, right? And a popular way of implementing that is a separate hardware token. But we know that separate hardware tokens have usability issues, right? People lose them, they break them. They don't like them, especially if they have to have multiple of them. And so they have a lot of usability issues with them. Well, one of the things we've been working on is how do you enable two-factor authentication without having to have a separate hardware device? So improving usability of security control solutions is a key element of avoiding compelling users to use these alternatives, of which they have so many. Social media is yet another example. I have this tool in their back pocket now. And lastly, security needs to be cost effective. If you'd like to read more about healthcare worker user experience with security and how it can impact their compliance with policy. Brian did a great job talking about what a policy should be, but user experience can impact the user's compliance with policy. If you want to read more about that and how it can bring additional risk, there's a white paper at the bottom link. Again, these slides will be published with the video of this session. I invite you to look at that. We're also going to be running a survey in January with HIMSS. Directed at frontline healthcare workers. How are they perceiving security? Where is it getting in their way? What are the workarounds they're using? Where are the compliance issues and the risk? If you'd like to be on the list of recipients of the results of that survey, I'd love to hear from you. Drop your card with me or email me. My email's at the end of these slides. I'd be happy to share those results with you. So that image on the right is one of my favorites because doesn't it say exactly what we're talking about here? Which is, for those that are in the back, there's a security gate on that road, right? And what are there tire tracks going around it on both sides? And isn't that exactly what happens? If you put security in the way of the user and they perceive it adds no value, right, they're going to circumvent it, right? And so what we have here is a placebo, really. I mean, it's not really delivering any security, right? So how does this manifest in healthcare IT? Well, slow encryption, again, can impede healthcare. Vulnerable security that gets circumvented or disabled by sophisticated malware and the device gets compromised, people seek alternatives. Unusable two-factor authentication, we talked about, expensive security. Healthcare solutions that cannot be properly managed. This is a real problem with BYOD because we have so much diversity. How do you manage these devices? How do you make sure they're patched, configured properly, diagnosed if there's issues, remediated? Manageability is a real challenge. If these devices don't work when the healthcare worker needs them, they could be compelled to seek alternatives, to use alternatives, which again bring risk. So one of the really interesting ones, and I'll show you some data in a moment about this, IT responsiveness. That's another element. It's not just the technical security controls, it's the responsiveness of the IT department within the healthcare organization. If they are perceived to be too slow to embrace new technologies, BYOD, personal smartphones, tablets, and so forth, the users, they still have these devices on them, right? And they're compelled to deliver better health care. And so this, what it can do is the use of these devices can happen sort of under the radar. So definitely agree with Brian and the panel here that, you know, proactive approach to embrace BYOD is better. Set your policy, do your risk assessment, get the security safeguards in place. And one of the very key ones is end user training, increasingly important because end users have so many tools now. If they don't understand the risks of using these tools, they could inadvertently use them and add a lot of risk. So moving forward, here's the results of a survey that was run by IPASS in Q3 this year, and it included healthcare, but it wasn't healthcare specific. And what they found was security is not required to access corporate data in 12% of the cases with smartphones, in 7% of the cases with tablets. That's very alarming. That's like wide open, no security. What they also found, which is very pertinent to the point we just talked about, is workers use workarounds to bypass IT in 24% of the cases with smartphones and 12% of the cases with tablets. And what's driving this? Slow IT organization, response times, strict policies, overly strict in the view of the end users. Maybe some of this is educating the end users why the policy needs to be that strict. But if the policy is too restrictive, you know, it can compel the workarounds and add risk. Workers really want flexibility and efficiency. These numbers are likely to grow as BYOD grows and IT control recedes. This is part of a broader macro trend we see where, you know, maybe 5-10 years ago we had a very sort of top-down command and control. The IT organization provisioned all the mobile devices and they strongly managed and secured them. It's going to much more of a, you know, BYOD diverse environment where it's much more of a detect, respond, and govern type security model. So I think these type of challenges will just increase going forward, and we need to make sure that we are proactive in heading them off. So we strongly advocate the holistic approach to security, and it starts at the bottom right. We've got regulations, privacy principles, standards, and it's about the business needs, right? What type of data are you working with? Classifying it according to its sensitivity, modeling the usage, what are the use cases? Those are informing policy, right? Policy provides a critical foundation for your privacy and security practice on which you can do risk assessments to identify the highest priority risks based on likelihood and business impact. Once you've identified your highest priority risks, don't think of just one control to mitigate the risk. Like if you're trying to avoid breach, don't just think of encryption. Think of a combo of controls, physical, administrative, and technical. Technical, definitely encryption in that case. But you need to educate your users so they're not choosing weak passwords. They're not putting sticky notes on their screen with the password. They're not sharing their passwords. You know, we know this happens, right? It's alarming how often it happens. So mitigate each of the risks with a combo of controls. Healthcare workers are critically important. Training the healthcare workers really important. The type of safeguards on the administrative side, policy, procedures, risk assessment, training, audit and compliance. But where we're really focused from a technical security control standpoint is something called hardware-assisted security. And what that is it doesn't really implement the whole security control. What it does is it makes it better in a sense. It makes it better in performance, so accelerating the performance of encryption. It makes the security more robust, so it can resist increasingly sophisticated malware that would seek to circumvent or disable the security. Makes security more usable, in some cases reduces cost. Okay, and in short, we hope to improve the user experience with security. In an ideal world, people never buy, in general, security to improve their user experience, but what we want to do is we want to prevent security from detracting from their user experience or impeding the user experience or the productivity or the quality of patient care. So we see this trend over time where in the past we had general sort of security software running on general purpose hardware, and there really wasn't a whole lot of security specific stuff in the hardware. In some cases we had separate security hardware. Good example we gave already is the two-factor authentication tokens, the separate hardware tokens, encryption acceleration cards. There's lots of examples. So we see this trend over time where more and more of the core security logic is moving down from the software into the hardware. What this means is there's actually instructions in the silicon, on the client side, on the back-end servers. Those instructions are actually doing some part of security. Encryption's a great example. So there's instructions that accelerate encryption, decryption, and harden it, make it more robust, less vulnerable to malware. And so this trend, in some cases, is going to include the consolidation or embedding of separate security hardware into the general purpose hardware, where now you buy a laptop or an Ultrabook and you have, or a server, and you have encryption baked in. And you get the performance, so you can activate the encryption without slowing your end user down. You maintain usability. So definitely see a lot more of this, where security is one of our 3 key pillars of focus. So look for a lot more security in future hardware products. So I'll leave you with that. There's some disclaimers here, mostly for those of you that will download the slides. But there's also some useful links here if you want to find out more about the specific elements I'm talking about. And with that, I'm going to hand over. Thank you.
Thank you, David. So I'm here to take a little bit different approach. I don't have slides to present to you, but I want to open up some other thoughts, and it's more around the data aspect of it and the true data aspect of it. So when I'm talking about that, what I'm meaning is, with electronic medical records, with EMR applications, with delivery of CPOE and devices being utilized right at the bedside, as well as BYOD and those devices also being utilized for that type of scenario. There's a lot of structured content that's delivered to that, right? And that structured content being the actual applications for clinical workflow that's being utilized. That content's fairly secured in its own right, and that content is controlled via that EMR vendor or the vendor that you're actually using to deliver the solution. What you find more and more is a lot of the communication actually happens, even some of the workflow happens outside of the context of that solution. It can happen with unstructured content, right? It can happen with documents via email, transferred doctor to doctor, clinician to clinician. It can be a PDF that gets shared between multiple people that's sitting in a shared directory. It can be a Word document, it can be an Excel spreadsheet with a bunch of Social Security numbers sitting in it because it's been transferred to a payer. So you have a lot of unstructured content that sits out there that people still look to access, right? So within that unstructured content, a lot of PHI can be housed within it. Well, clinicians at the same time, with their edge devices, want to have access to that. Possibly it's something they've accessed on their laptop, and then they've signed up for that free 5 gig account up in the cloud from that latest provider. And they push it up into that cloud provider, And now they can access it on their edge device. They can access it on their pad, Android, iOS device, whatever that might be, and actually gain use from that, right? They can actually leverage that and use it as part of their clinical workday. Well, what happens too many times once it goes outside of the organization, right, and gets put into that cloud provider for the free 5 gig is now that content has left the organization. And now you have unsecured PHI sitting out there in some erroneous cloud, and you're not aware of it. So the thought is more taking an approach, and I hear this from docs, I hear this from clinicians when I go around and talk with clients. Too many times we in IT and establishing the environments for the organization, we're following the trail of what they're dictating to us. You know, they're asking for applications, they're acquiring new clinical apps, and those apps are being pushed down, and IT has to support it, and it is what it is. Too many times we're not ahead of the curve, right, with those types of solutions where we might be offering a cloud-based solution or a solution that actually offers them the accessibility that is controlled in your own environment. One that takes the data, I mean, as we heard, right, 3 devices are a common scenario, right? A lot of people initiate some of their initial work on their laptop, but then they push it up into that cloud, and then they access it from all their other devices. Well, if you took the opportunity to have a solution put in place that actually took all that data off that laptop, backed that up, put that into a central repository, and then gave those individual clinicians access to that content that they want to maintain and store, then you have a central spot inside your organization, inside your controlled area, somebody that, of course, will apply the policies and the rules. Then beyond that, if you have a solution in place that actually takes and can index that content. So now what happens is if you have content that's sitting there that is unstructured, and you have a situation where litigation occurs, Jay Saviano comes after Hospital X because of content that was leaked or breached or some sort of violation, you not only can search through all the EMR content, but you can also search through that unstructured content with a full e-discovery solution. Search into email, search into unstructured content sitting in basic directories, search in PowerPoint presentations if Jay's name was ever used in a presentation at a show like this because they wanted an example, right? You would have all that context controlled and within your own control. And therefore being able to set policy around that content and maintaining the retention around it. So it goes back to that comment of what Lisa had said around, you know, upwards of 30% of devices are lost. So why let that content actually be pushed constantly out to that device without understanding what is actually on that device, right? And maintaining that control. Giving access for potential download or setting the policy to say, no, you can't download, but what you can do is you can view. Or what you can do is email, because then once I know you put it in email, I know I can index that content as well. And so those are my main points. I'd just like to open those up as thought points. I think we have enough time, we'll definitely have enough time for conversation around it. But it's really a driving approach, more so in healthcare. The big concerns around unstructured content. Everyone talks about the structured stuff and all the applications that are there. But the unstructured content is really what can get people in trouble, get organizations in trouble, and can truly set out there as a component to circumvent your own compliance policies that you feel you have well covered across the board, but it's that one Excel spreadsheet that turns around and throws a whole monkey wrench in everything, right? So, thank you for your time.
So we've had a lot shared today across our different panelists, and again, like Jay, I wanted to provide some additional thoughts layering on top of what our other panelists have shared. Truly, the cow has left the barn. We know that within the clinician, professional, care managers, and so on, that space, you're seeing adoption of smart devices far surpassing the rest of the population. So an estimated over 90% of physicians now have smartphones, an estimated 60% of them have tablets versus 30% last year. So that's increasing more and more. But what's also interesting, though, is that when you actually ask the physicians and the clinical care team how many of them are actually using those smart devices for clinical applications, that percentage is actually still in that 20-30% of the smart device owners. So they're not quite using it for, clinical situations, but more around still the usual things of being able to surf, text, email, and so on. So that's just one thought to leave you right now. A second thought is that when we look at these different solutions to compel security on these bring-your-own devices, we have seen at AT&T this evolution to better and better solutions. So you start first with the virtual type of solutions like Citrix. So basically what you're typing on your smart device or on your mobile device, it's merely capturing the keystrokes. So nothing is really retained on the device, so there's nothing to lose. That's first generation, but of course, then you have the issues of latency. If you're not in network, you basically can't use those applications. Second generation is where you have applications which are read-only. So you've got EMR, mobile applications, but they're read-only. So again, limited functionality for you. You then have these, the next phase, which are these applications that compel you to put in two-factor authentication that our panelist from Intel has shared with us before. It comes with its own challenges. But I submit to you that I think the future here are applications that allow you to be able to have both a personal as well as a corporate persona on the same device. The idea here being that you can toggle, and actually this is an AT&T solution that's come out called Toggle, that allows you within your device to have a whole separate persona that comes with your own phone number, a separate phone number, a separate data plan, and embedded within that a corporate email, corporate calendar, and all of that secure. So the idea here is, can we use that kind of technology to allow an individual, because one of the issues with bring your own devices, despite best efforts, sometimes you have your own personal device, but you also have your corporate device, and there are issues around that ease of use that we're talking about. But the final point, though, as I think many of our panelists have raised before, is at the end of the day, no matter what technology solution, no matter what policy you put in place, it's only as good as the people who are going to be following those policies. When you look at the ONC website around HIPAA violations, when we first looked at it, we thought we were going to see a whole bunch of, hacking, server issues, but as we all know, most of the issues around lost data is around laptops being left on trains, laptops being stolen, there was no encryption on the data, so that's an issue. And we see that compounded even more going forward, because not only are we seeing a trend of bring your own device, we're also seeing a trend of bring your own application, where applications are downloaded onto the phone without corporate sanction. Sometimes they're homegrown. And also, interestingly, a trend, and I'd love to hear thoughts from the audience, from hospital CIOs, where they are looking to the physician and the clinician to be the primary decision maker in going to a separate site that they sponsor to download the appropriate mobile device management application tool, whether it's AirWatch or Mobile Iron or a different MDM solution. So again, as we see this tension between the hospital CIOs wanting to balance security, but at the same time allowing for that flexibility, and at the same time trying to figure out the cost elements, that's where I think, we face the combined BYOD/security challenges.
Okay, well, that was a lot of information from some wonderful panelists. So we have microphones in the center aisle. And I'd like to start with the gentleman here, and then please join in, let's have a conversation.
My name is Ali Simon. I work with Kaiser Permanente, and I personally have been in the space of communications between physicians and their patients, and kind of gotten the cutting edge of that since '96 with telephony and now text messaging and so on. It seems to me as though the HIPAA violations are fairly subjective, at least the development of those, and it's very hard to put a finger on exactly what's okay and what's not okay. And certainly patients want to have their information. We give them access via the web. Now everybody's carrying around their computer right here. Why can't we give them access here? Yet the restrictions around the mobile space seem to be more uncertain and seem to be more strict. At least my impression is. So I think there's a lot of concern, certainly among the legal staff, about what's okay and what's not okay. And as I say, it seems to be very subjective. Now, from the patient perspective, they want to get their information. Maybe it's an appointment reminder. Well, appointment reminders can be delivered non-securely for some reason, even though I know as a physician I would have a spouse, a person who would not want their spouse to know they had an appointment with me, is delivered non-securely, and it's okay. Whether it's a dental or a doctor appointment, you can deliver it non-securely. On the other hand, we have PIN numbers and birth dates for secure information. Now, it seems as though we're getting shackled by these restrictions. So I'm thinking if a patient wants to receive, as an example, let me go on the edge here and say they want to receive some of their test results on their mobile device by a text message. If they sign the terms and conditions that say, I'm okay with this, I accept the liability, the possibility that my device could be sitting on a table or whatever and somebody else could see it. Is that okay or is that not okay? And that's kind of one of the areas I want to talk about is what's okay and who decides what's okay and when do you get your wrist slapped?
Is that Brian?
Yeah. Remember that disclaimer on the last slide that I had? Kidding aside, fundamentally, we own our information, right? Me, as an individual, I own my information, whether it's medical information, and if I choose that I want to allow that information to be disclosed and to be shared in a way that falls outside of the regulations under high-tech and HIPAA, I can sign away those rights. I'm not aware of anything that prevents me from doing that or anything in HIPAA that specifically says I can't do that. Now, how you set that up is a wholly separate issue, and how you're going to get the consents and how you're going to be sure that they are the right kind of consent, meaning it was done consciously, knowingly, aware of all the risks, so on and so on. This is why I'm sure your attorneys at Kaiser Permanente are, the problem is this is not unlike really any other area of the law that has a technology implication with it. It's changing every day. I have to go I have to go every day on these sites to see what's going on because it changes every day because of the way, when they put HIPAA together, first of all, keep in mind it was an administrative simplification regulations when they, right? I mean, that's what it was when they drafted it and put it, they thought this was a good idea because it would help everybody simplify things. It's not really kind of turning out that way. And HHS and OCR and everyone else involved, they're struggling too. I don't view them as the bad actors. I think they're just like everyone else. They're looking at this and saying, man, things are changing like this. How are we going to keep up with this? I think they're doing the best they can to deal with it. One thing I didn't mention during my discussion, and that I would encourage anyone here who's involved in this, if you haven't looked at the OCR, HHS OCR website with respect to the audit protocol, if you really want to know what's required and expected, go look at it. You know, the problem is there's 78 criteria under the security element, 81 under the privacy, so there's a lot of stuff in there. But, and it seems daunting, but if you really scale it back, it's, you know, do you have reasonable safeguards in place? Physical, administrative, technical safeguards, and you can find guidance in there for that. But I agree with you. I understand what the issue is in terms of patients wanting to be, and you know there are I don't know if non-clinical is the right word, but there are websites out there that aren't particularly sponsored by any healthcare system where people share PHI all the time, freely. You know, these support groups, diabetes, whatever it is. And they're doing it willingly and openly, and nobody's at risk for that because they're doing it willingly and openly and knowing that it's going to be out there. So, and the last thing I'll say is I have a client that's in a physicians association, and we had this discussion 6 months ago, and he was laughing. He said, you know, from an individual, he is a physician, from an individual standpoint, he doesn't care who knows what about his medical information. But that doesn't change the environment that you all have to operate within. Because if you don't, you know, I ran through the litany of recent cases with OCR, and that's not going to change. And the other thing I didn't mention as well is it's not just OCR. As many of you know, they've given the state attorneys general the ability to go out and enforce HIPAA as well. So, you know, California's kind of in debt. Maybe their attorney general's looking at, you know, I don't know that. I'm just throwing that out there. So understand the issue.
Certainly agree with those points. The one thing that came out for me in that question is security takes second seat, right? It's about healthcare. It's about the patient. And that's the natural order of things, and I think that's the way it should be. But the second thing is, you know, when we talk about risk, we've always got to talk about it in the context of benefit. What's the benefit? Then we can look at the risk, because it's a trade-off, right? It doesn't make sense to talk about risk alone. Because sometimes a higher risk is okay if it's delivering a very compelling benefit, right? A great example is break the glass in an emergency scenario. Break the glass, the caretakers, caregivers get full access in order to save that patient's life, right? But the other thing I wanted to emphasize is risk assessment. Yeah, I don't think there's any substitute for doing the risk assessment. It's required by HIPAA. It's required by meaningful use. It's required by best practice standards like ISO 27001. Doing the risk assessment allows you to identify the highest priority risks. For example, you do the risk assessment for your patient portal type or patient communication type scenario. You're going to use that to identify your highest priority risks, then apply safeguards to mitigate those risks. But you can also use that risk assessment to fully inform the patient of what rights they're waiving. You need to inform them, these are the risks. That information could be intercepted in transit, and then they're fully informed, and if they waive it still, and that type of breach occurs, then, you know, it holds water better than it would if they weren't aware of the risk.
I just want to make one last comment. I think we forget sometimes there are two sides to HIPAA. There's the side of HIPAA that's, you know, be very careful about who gets access to data and work through the workflows, et cetera. The other side to HIPAA is the right of an individual to the healthcare information. And the biggest fine on that OCR website that we've seen to date is actually of a healthcare enterprise that refused to provide that data to their patients. And with meaningful use stage 2 and the need to continue to provide that information, this tension will only heighten. So thank you for bringing that up.
Right, and so specifically with regard to the right to their information, that's codified in ARA High Tech, where there were new individual rights given to patients with regard to their data. So that's part of the balance as well. Thank you, Eleanor. Let's go to the next question.
Okay. Gopal Srinivasan. I'm from Aetna. By the way, great topic, very well presented by everyone, so thank you.
Thank you.
The question I had was, I think we went through a list of policies, and it certainly was apt and actually judicious to put a policy in place. But given that this is a device owned by the employee, not by the institution or the corporation, to what extent would you go in putting restrictions and limitations on it? I mean, would you, in essence, pretty much modify the employment acceptance policy? Because, that's part of accepting an employment with an institution, because at the end of the day, it's their device.
And that is, excuse me, I spoke on this topic at a more general conference in October, and that same question came up, and it's a really good question, because many advocates of these kinds of policies say you need to have and I'm going to get the terminology wrong on this, but basically the ability to wipe a device clean, right? And that's a big issue, because when it came up, there was a lot of exchange in the room about that, because the individual, as you've identified already, if they're using their own device, I have my Android phone here. What's on this phone? Well, I got a bunch of pictures on here of my family, right? And if I go to, and I use this for work, and we have a policy, and I understand, and under our policy, if I lose this on the train back to BWI, it's going to get wiped. Now, I know that going in, and I made a conscious decision because it was communicated to me clearly. Now, I happen to be buddies with our CIO, so he tells me everything that's
Always a
going
good
on,
idea.
right? But, and not to say he wouldn't wipe my device clean if I lose it, but I knew that going in. But it does raise the issue of, can employees, and especially in healthcare systems where you have physicians, my dad was a doctor, so I can say this, they have big egos. A lot of physicians have big egos. And they want what they want when they want it, not unlike lawyers, right? We want one when we want one. We want it. So there is that tension, because there's another school of thought that says, no, what we're going to do is, rather than get into all that and worry about it and have to fight 100 separate battles with 100 separate individuals who have their own, we're just going to give everybody an iPad. Right? We're going to go out and buy the iPads. We own them. We control everything that's on them. We can do whatever we want with them. You spoke to the thin client issue, and I laugh about that, because 20-some years ago, when I worked at a robotics company, we had everything was thin client. Everything was thin client, and I went through that whole evolution of, we need a desktop computer, and it went through that whole thing. And do we allow external email? That was a big issue back in 1995, right? And then the internet. But so it's that creep, the technology creep, the advancement of the technology balanced against the tension of the things that you just described. And is there one answer to that? There is not one answer to that. And that goes to my point earlier about you got to know your organization. You got to get the right people involved early on when you're starting this process, so you can get a sense for where people want to drive this. And if you give them a choice, maybe you go to the entity and you say, all right, here's where we are. We understand people want to use their own devices on the one column. On the other hand, if we go that route, this is what you're going to have to agree to. And you need to understand all of these things. And I like that concept of, two different identities, and I understand that as well. I happen to have more than one identity myself. But I get that sort of, I don't know the technology, but I get that concept as well, where if you have one piece of hardware, but it can really be two different pieces of hardware, if that makes any sense.
So at HIMSS, through our mobile security work group, we took a look at that issue, and we came up with a recommendation to implement a separate user agreement where all those terms are documented and have them sign it. So in our toolkit, we have samples of ones that are actually currently being used in organizations.
Now I know why you were trying to interject.
Sorry. I just, I think from what I hear from our members, people get really upset about you wiping their pictures. And it's amazing how upset they get. So that's like line number one of most of the samples I've seen. And so we put it out there. You really need to think about making it clear to them in writing what's going to happen. Next question?
Sorry, just to add one more
sorry.
point there, I think that's another compelling reason why to have the separation on the client device, so that in the event of loss or theft, only the partition, the organization part of the partition gets knocked out. it's one thing having personal photos wiped out, but what if that patient has, medication reminders on their calendar or something? That could directly impact their health, right, on their personal calendar.
Thank you. Next question?
Hi. This is James. I work with Research in Motion, the BlackBerry company. And so it's interesting because as today, the keynote presentation was by the CEO from Aetna, I think the first day. The core concept he was talking about is consumerizing healthcare. In other words, bringing in the core workflows, which he thinks is inefficient, into the consumers, and mobility being the core platform for that. We at RIM, we did run into this problem 10 years ago where corporate communications was a workflow we were trying to externalize, bring into the hands of phones so that emails can be made secure, and we ran into all the problems you guys talked about. So we do see strong parallels between that and what is happening in healthcare in terms of mobilizing the workflows. Do you guys agree with the comment? I'll appreciate your comments on this front.
Sorry, was the question around how do we mobilize workflow?
No, the core parallels I see between what is happening in healthcare in terms of bringing the workflow from within a hospital to outside, it's also very similar to the problem of what we saw when we tried to bring the corporate communications, email from within the company to outside. So we see a lot of parallels between these problems in terms of security, in terms of everything. We've done toggles, something we've done in terms of balance. We've done sandboxes, we've done MDM, all these things. So we see a parallel between these two problems. And do you guys agree with the comments?
I completely agree that there are strong parallels. I think, though, the issue is in healthcare, the added complexity and concern here is around the PHI component. So that adds, even more concern around what kind of security measures that you put in place in order to protect that flow of information. And of course, no matter how many end-user license agreements and tweaking of that, at the end of the day, because of the way we understand how the laws are written, the corporation who's providing those software solutions and well, maybe not the hardware, but the software piece, they still are liable for being fined for not complying with the protection of that information.
I think those are great points. Just to add to that, I think it's generally accepted that healthcare doesn't necessarily lead in the security space, so they're a little bit slower to encounter some of the issues that appear elsewhere. I think another interesting observation is that, what we're encountering inside organizations now with BYOD, that diversity has existed on the external side of healthcare organizations for a long time, right? The way patients are trying to connect. And so that, a lot of the same things have been seen before, even by healthcare, and we're seeing them internally now.
Yeah, and additionally, RIM by far was at the forefront of establishing policy on edge devices, and that's why, a lot of those devices were at the forefront in healthcare organizations. And now what you have is with BYOD, there is no common device, right? You're dealing with an iOS, an Android, a Microsoft, and a RIM environment, right? And you're dealing with this across the board. So it's very challenging for IT. Once again, because like those clinical apps that are deployed in the environment, the clinicians set the direction for the technology, and IT has to inherit it, right? And so that's what we're challenged with every day, is inheriting the fact, because, it's not to say that there won't be another device in the mix here soon, right? Who knows? So that's a huge challenge, and RIM was at the forefront of setting policy around that. And it'd be great if there was one tool like a best server that you could set policy across the board in your environment for all those devices, but it just doesn't seem to be there today. But that's my only point.
Okay, next question.
So this is a question from a totally different direction. I work with a company called Griffin, and we're developing apps to try to solve some of these problems. And let's see, we're looking to create solutions for protecting and encrypting data. And you covered the importance of the delineation between professional and personal identity. being able to use a singular device in order to communicate professionally and in your private life and have a line so it protects your personal privacy as well as your professional identity, as well as having encryption and two-factor authentication on the device. The problem is that discovering what these issues are is kind of like a treasure hunt for the app developers. We're digging through the internet trying to find these articles and coming to these conferences in order to hear these perspectives so we know what problems we should target and what problems aren't really problems or we don't need to deal with, that sort of thing. I'm looking for a kind of how to create a feedback loop so what we develop can be vetted or just to hear something so we know that we're going in the right direction and that the problems that we're targeting are actually the problems that need solving.
Your answer might be
I'd love to respond to that. I look at security and privacy for a hospital, and you mentioned the interns, the residents, the move around. While they're in our environment, they're working on their mobile devices that we provided, they're using the right corporate email, but when they move and rotate to another hospital, and leave us on Friday, and Monday they're at another hospital, they're responding by Gmail. So you could do something that would look at, and somebody else is receiving it in our organization and responding to them. Well aware that they shouldn't be talking about this patient or the Gmail, but that's now the only email communication we have for that resident or that person who is right now working with us. If you could develop something that would sniff this email in our corporation is now going to Gmail, wrap it up and flip it, make them have to go someplace else to think about this would be greatly appreciated.
Well, we're doing text messaging right now, but maybe we'll go that way.
Anyone else want to tackle that?
One other comment is, there's no substitute for getting the early release out there as quickly as possible and actually getting your end users to comment as well on other use cases they may see, to broaden your coverage. I think that's the best way to get targeted feedback. There's lots of forums out there where you can get that.
I guess my question is that you're looking for like a one-stop resource that you can go to that as you go through your use cases or your iterative process of development where you can get a check back that says, well, have you considered this regulation or,
It's kind of two-sided. So in the doctors that I talk to, they don't know where to go in order to find the apps that are okay for their hospitals. And from our side, we don't know. Like we develop these solutions. Okay, we have a PIN code. Every text message is encrypted on the phone in transit. But are we solving the? I noticed that a lot of the companies are saying that they are HIPAA compliant, and that doesn't. You can't quite say that. It's got to be part of a policy.
It doesn't make
Exactly.
sense.
So, but we're saying, these companies are saying that because we're trying to convey a message that we can solve your problems, but I want to make sure that we can.
well, as far as probably one of these three is better able to answer this than I am, but I believe there was some guidance issued not too long ago about encryption. Now, high-tech, let me back up one step. One of the things about the high-tech amendments to HIPAA was, it's aimed at, electronic health records, EMR, EHR. And what it says is there's a data breach requirement in it, notice requirement in it, but it says in order to get around that, you encrypt the data. And then they set out some guidelines about how you can how you can encrypt to meet that requirement. I don't know if that's a part of what you're trying to drive at or not. And I think you can say probably that in terms of the encryption requirements that were set forth in the High-Tech Act and the regulations that came out after it, we believe we're in line with that.
Well, and it essentially offers a safe harbor from that reporting requirement.
Some things that came out there which I think are really key, and I wanted to share some personal experience. I think healthcare, we've had limited success with healthcare saying, here's some technical security control, have at it. and leaving it up to them to figure out how it actually helps them achieve compliance. Regulatory compliance is such a key driver in healthcare that one of the things you might consider is actually working through the same process a healthcare organization would to ensure regulatory compliance. So understand the regulations at play in the geographical areas that you're targeting. Actually do the risk assessment for the use cases that you're targeting. You mentioned text messaging. What are the other use cases? How is the information flowing? Where are the risks to data at rest in transit? What are all the risks? And then tie what you're doing for security controls to those risks. Then when you actually go into a healthcare organization, you're not just saying, here's a technical security control, have at it. You're showing them how it ties into them achieving regulatory compliance, which is more often than not what they actually want.
Good idea.
Just one last point to add here that, yes, agreed, the marketplace is extremely cluttered with applications on the professional side as well as on the consumer side. And so you've got companies like Haptik coming out and saying, I will filter it for you and I will let you know which of these are the most useful. I know something similar is happening on the consumer side, meaning the patient side. But at the end of the day, no matter how great that application, no matter how great the functionality, there is still the challenge of integrating that solution with the back-end system. So if so oftentimes the physician would say, hey, wouldn't this be a great functionality, but they don't see behind it that in order to get this specific use case integrated into the workflow and into the legacy IT systems brings with it its own challenges, which isn't associated with the HIPAA issue, but it's all around the, how do we get an application that truly would meet a real need within the clinician setting.
So, and one additional point, from the regulatory standpoint, we know that there are several agencies that are looking at the medical mobile application space. There's, of course, HHS, but there's also the FDA and even the FCC. So I would keep an eye on that space. With regard to the FDA, they're taking a very serious look at what turns an application into a medical device and their jurisdiction to regulate that. There is discussion within the industry about application certification and whether we can do that and whether that would help with the issue of potential regulation. And this is all in early discussion phases. I think something to keep an eye on. At HIMSS, we do track that, and we will be, we'll push out information where we can. It's just not solved yet, and so we're tracking it pretty closely. Now, I want to get to the last question. I think we've got about 8 minutes left, so.
I'll be real quick. Hi, my name is Ann Wright. I work with Hewlett-Packard. So this is certainly near and dear to our heart, this topic. But one of the things that I question is, or least like you to keep in your scope, is the millennial workers that are coming into the workforce, particularly in this area and other companies, are very tech savvy, and they probably are the biggest pain point to most people of them circumventing the system. So anything that IT comes up with, they know the hacks to get around it. So, and everybody always nods their head at that, but that, we hear from CIOs, is one of their biggest pain points. That's your visual. The other thing is are there in healthcare different security levels for different roles? So, for example, physicians, doctors, nurses may have a very different security clearance than somebody who might be housekeeping in a large hospital. And so that when those levels are then set based on role-based, so, a dietitian might not have the same level of clearance as a physician would have. Is that going on or are we really just trying to build a security standpoint and have everybody follow the same policy?
Oh, there it is. Okay. Sorry, I think that absolutely is in place. I mean, the role-based access control needs to propagate to mobile devices, and the role does matter. It matters the amount of authorization they have, what kind of services they can access, what kind of data they can access, what they can do with it. We also have had network access control for a long time. So if you're logging in, what do you get access to? It depends on your role, right? And one of the areas we see growing in the future is something called client-aware cloud, where the cloud becomes aware of, we talked about device diversity. The cloud becomes aware of different devices because how the cloud responds to a client to deliver the optimal user experience depends on the capability of the client. Are you dealing with a very small smartphone? Are you dealing with an iPad? The cloud could respond in different ways to deliver an optimal user experience. Now, the security dimension to that is, what type of client device is accessing the cloud? Where is that device, even geographically? What kind of security does it have on it? Is it personal? Is it corporate? What it's really doing is it's building a risk profile of that client, and it grants access not just based on the role of the user and how strongly they've authenticated, whether it's just username and password or two-factor, but it's granting access based on the risk profile of the client. So a client that is, a corporate device that's strongly managed, strongly secured, it's coming in from a geography that's, expected, a time of day that's expected, is going to get full access to the whole, healthcare suite and sensitive data. But one that comes in from a geography that's, halfway around the world where they know they don't have any workers, it's a weird time of day, it's username, password only authentication, that risk is much, much higher, and access will be granted more restrictively.
Well, and I guess part of that also is them using their own devices. So if someone who's a physician uses their smartphone to send text messages and photos, that they're able to do that versus another role who they're not allowed to do that within the confines of that, their role.
As far as the millennials, and no offense to any millennials in the room, but you just fire them if they're breaching the policy, and that would apply to anybody. I mean, that's what the policy's for, and the enforcement, to be honest. And you have, anti-jailbreaking, that kind of thing in the policy. So, and I mean that seriously, and it does need to be enforced. But now I forgot, what was the second topic we were talking about? Oh, on the authentication, I agree, and that would be as part of the policy as well. In terms of levels of access and who gets access to what information and how they can use it. And that's how that's dealt with. So.
And for
Just one more comment, sorry. One of the ways that policy is enforced is a very important safeguard that's emerging is data loss prevention, DLP. If you haven't heard about DLP, I definitely recommend going deep on that. Endpoint DLP, network DLP, but you basically have policy, you configure the device, what can the user do, what can they not do, and DLP can actually more often than not catch the user before they make a mistake and send PHI in the clear. That's an important tool. But there's, for every safeguard, there's always ways of circumventing it. Of course, if you have unstructured data, to your point, DLP doesn't always help. So it's just one more safeguard in a multi-layered approach.
And one more safeguard is you have to do audits of employee behavior. You have to understand what those millennials or others are doing, because I've talked with organizations that get really surprised by what's going on. And so your policy may not even be up to date with what they're doing. You don't know what they're doing, so you can't enforce it, and you can't apply sanctions. And it's amazing the number of organizations that just really never observe what their employees are actually doing. So that's another important point.
The other one, too, is, I'm aware of companies out there that do actually location-based policies. Location-based policies of once you connect to the Wi-Fi environment within that clinical space, now policies like disabling cameras, or disabling cameras possibly just for housekeeping as opposed to the clinicians. So there are solutions out there with those type of policies that can be pushed down to an Android, an iOS, a BlackBerry type device.
So we've seen clinicians, nurses, taking pictures of patients and posting them on Facebook. So, again, it would make sense to say it's only housekeeping and not the clinicians, right. But really, you got to know what they're doing, or you can't have a policy that prevents it. So.
That goes back to people.
Right. People, yes. It's really amazing. And, in their defense, I would say that one of the biggest complaints that we hear is that, they want to collaborate, docs collaborating over Facebook because their tools in their own environment are not conducive to collaboration. So you really have to get back to what's the core problem. But again, you give them a mobile device, all kinds of opportunities for poor behavior are also given to them.
Yeah, that's to my comment when I talked. It's docs, clinicians say, I want you to think in advance of what I'm needing. I don't want to, Dropbox comes out with technology, well, that's great, I'm going to sign up for that. You should already be offering those types of solutions or to your organization as a whole. So that's how you're proactive, and that's how at least you can control the data. Otherwise, they're going to, once again, like your slide showed, they're going to go around the gate and they're going to find a way.
So just one more comment and a reminder really is we're going to be running a survey with HIMSS in January, which is to tease out these exact things. Where is security getting in the way? Where are users circumventing it? Where's the risk? Where are the non-compliance issues? And so if you'd like to look out for that, certainly. If you'd like to actually get that report when it's available, I'd be happy to send it to you. Just let me know.
Okay, well, I would like to thank our wonderful panel and also the audience for the wonderful questions, interaction. Thank you very much.